Today on the Auto Contouring Review, we'll be looking at a paper on recommendations for implementation and quality assurance of artificial intelligence in radiotherapy. This paper is very much like a supermarket special offer. Buy one, get two free. It has 3 joint first authors. While I'm a great fan of joint first authorship, in many papers, several authors have contributed heavily to the paper and deserve equal credit on it. It does come with a challenge, and that is when you invite one author to discuss a paper with you and you end up interviewing 3 of them simultaneously, as I've done for this paper. This paper is quite broad in discussing all of AI in radiotherapy. Since this video is the auto contouring review, however, we'll be focusing down on just that contouring piece. But as a broad paper, it does cover all of radiotherapy, and their first figure in the paper looks at that workflow and highlights places where AI is being used clinically, those blue boxes. And I'm sure there'll be additional boxes to come in the future. What they present in this paper is a look at how we implement AI for radiotherapy. The first 2 of these sort of light blue boxes on this figure represent that training and commissioning stage of developing an AI solution. And then the final blue box goes on to the clinical commissioning and continuous monitoring of AI in the clinic. This is where I think the paper really adds value, particularly with this little purple box, where they look at this continuous use. A lot of academic studies, clinical papers, stop at the point of commissioning, or clinical commissioning. A model's been developed, it then gets tested on independent test set, an evaluation is performed of how good it is clinically, and then it gets put into practice in the clinic. And that's where we stop, and the use in the clinic becomes a black box. And the recommendations presented in this paper go further in talking about how we're going to monitor an AI tool in the clinic on an ongoing basis. How do we perform patient-specific quality assurance? How do we perform routine quality assurance? I think that's an interesting and important contribution made by this paper. This paper is a recommendation paper. Essentially, it's a lot of words and not much in the way of figures or technical development for me to explain to you. And I'm afraid to say, if you want to know more about this paper beyond this video, you're just going to have to go away and read it. But before you do that, let's hear first from the 3 joint first authors on their thoughts of the use of AI for contouring in clinical practice.
Hello, thanks for joining me today. To start off with, why don't you all introduce yourselves and say a little bit about what you're working on. Should we start with Liesbeth?
Okay, hi, I am Liesbeth, and I am working in Leuven at the University Hospital in the radiotherapy department as a PhD student. And my PhD project is about the automation of the treatment planning workflow using convolutional neural networks.
Thanks, Anna.
Hi, my name is Anna Dinkla. I work as a medical physicist in training at the Amsterdam UMC hospital at the radiotherapy department. In my previous work, I worked as a postdoc studying artificial intelligence applications, mainly synthetic CT. So that's how I became involved in this field of work.
Hi, my name is Miguel. I'm working as a PhD student at the Iridium Cancer Network in Antwerp, Belgium. My subject is around exploring the applications in radiotherapy, but now my subject is more on the QA of radiotherapy.
Great, thank you. Well, this paper, I think, has come at a much needed time, really, looking at how we deploy artificial intelligence in the clinic. For this conversation, we're really going to focus very much on the auto-contouring aspect, since the YouTube channel is about auto-contouring rather than just AI. But Liesbeth, does the use of AI for auto-contouring really change anything about commissioning, or is it essentially the same? What do you think?
Well, for AI applications for auto-contouring are mostly based on convolutional neural networks, and convolutional neural networks need to be trained on data before you can use them. So yeah, so the commissioning phase, if it is different from other auto-contouring models, depends on whether your model is trained in-house or not. So in our paper, we included this training and validation phase into the commissioning phase. So if you develop your model in-house, you have to train and validate your model on data. And this is really different with compared to other auto-contouring techniques, like, for example, registration techniques. But the testing phase itself is mainly the same as for other auto-contouring techniques. So you use the same quality metrics or the same evaluation metrics and so on.
Yeah, and you highlight the need for commissioning to consider the end goal of auto segmentation. For example, time saving. Anna, do you think that that is the ultimate goal of auto contouring? Is it just about efficiency, or is there more to it?
Yes, there is more to it. It's also very important to standardize our delineations and decrease the inter-observer variability, so that users between each other make more the same decisions or make more the same contours. But I do think that efficiency is very important, because it takes a lot of time from our radiation oncologists and also RTTs to delineate, and it's in a way a shame if it can be automated. They have time, if it can be automated, they have time left to do other things, like focus on the more difficult cases or be present at an online adaptive session where they do delineations, or they adapt only the delineation for a fraction, so at one day, and it really enables adaptive radiotherapy, which was not really possible before, and that's a very big step in radiotherapy, to adapt the plan to the day and to the anatomy of the patient on that day.
Yeah, so I guess the efficiency aspect there is what's going to drive it into the clinic, and the other aspects, such as the sort of decreased variability between people contouring, is just an added benefit that comes along with it.
Yeah,
perhaps not the driving factor.
No, it will be very good to have less differences between users, also to study the results in the end, but it's definitely not, I don't think it's the most important aspect.
And when considering case-specific QA, the paper discusses independent methods to highlight potential error. So, using, say, a second model as a way of testing that first model. How can you ensure independence of the models? And following up on that, really, can that approach really reduce the burden on clinicians, or are they just going to have to check the contours anyway? Michael, maybe you want to...
I can answer that question. For auto-contouring, yeah, the main verification of your auto-contouring will be a manual verification. But those independent models, they will be used to flag out some potential errors. But how do you create so independence? I think if the model that you use for your verification, the second offline algorithm, when it's trained on your with the same data than your intentional model, then there is less independence than if you use, for example, a model from another company. Then there is more independence, more than it's when then but then it's more inferior from the start, I think. So I hope that's an answer on your question.
Yeah, I guess it's a challenge there. You know, if you train it in the same institution with the same data, it's less independence. But if you train it with a model or use a model from a different institution, a different company, we're going to have the challenge of potential contouring variations between those.
Yes, indeed. Yeah.
And in addition to that case-specific QA, you also discussed the idea of doing routine quality assurance, essentially as you would do for a linear accelerator. Do you assume in that there is a static AI model that once a model's been commissioned, or do you consider in the paper the possibility of having sort of continuous learning and continuous development? I don't know who wants to tackle that one.
Michael, do you want to stay?
Yeah, I also want to answer this question. This paper was actually written for people who already worked with AI, but also people who wanted to start it with AI. So I think it was better that we explained this with a more static model. But indeed, continuous quality improvement is actually the next step to your case-specific and to your routine QA, but then you need a more streamlined feedback system. But this during the written, this was also actually a bullet point, a discussion point, because case-specific and routine QA is actually a prerequisite of your continuous quality improvement, but you can also turn it around that after that you use with your case-specific QA, you can highlight some deviations. So you're actually going to select the suboptimal delineations, and then in a continuous quality improvement, you're going to use those segmentations to make your model to train your model, so you can continuous learning. But those delineations can be suboptimal also, so it is not necessarily going to make your model better, but in another way, it's going to make your model more robust. So yeah, it's a little bit of the two.
So I guess in a way, then, you know, doing that routine QA, doing that case-specific QA, is a way of helping with move to a continuous learning model.
Yes, indeed.
And until clinics have got used to doing that in practice on a static model, it's too much risk to move to continuous at this stage. But it is an enabling technology, really, or an enabling process. And one of the other interesting points in the discussion, you raised the concern of sort of disappearance of domain knowledge, that if the auto contouring has started doing the contouring so well that the clinicians don't really even need to check it, the physicians, the dosimetrists are going to start to forget what correct looks like, and that they won't be able to do that checking. How can we ensure that this doesn't happen? And do we need to ensure that this doesn't happen? Liesbeth, do you feel like answering that?
Yes. So I think it's important that domain knowledge doesn't disappear, because I think there will always be cases for which the auto-contouring model doesn't work very well. For example, we had a certain case in our institution because we used an auto-contouring model for head and neck patients. And that model is trained in patients that lie flat on the table when taking the CT scan. But once there was a patient that couldn't lie flat with his head, and so his head was a little bit tilted. And the auto-contouring yeah, it was completely wrong, like the mandible was in his head and so on. So there will always be cases that need to be corrected by the physicians. So it is important that the domain knowledge remains. And I think, yeah, it is, yeah, how can we assure that it remains? Well, first of all, they have to do the corrections. So in this way, they can train themselves. But I also think when there, for example, there are new guidelines or there are new CT scans for which the auto-contouring model doesn't work, you need to retrain your model on new data. So you have to create this new data and new contours. And this is also a way to train the physicians to do so.
Maybe we should also switch off the auto contouring, once a week. Yeah, just to give them a few cases to work on manually.
Yeah, maybe.
It's a good idea.
So I tend to ask this question, and I think for your paper it's pretty obvious, but I'll let you each give your take on this. Why should people go away and read this paper? Anna, start with you.
Yeah, I think it's a very comprehensive overview for everybody who's starting with the introduction of AI or starting to get some experience with it. But also for more experienced users, it might give them some new insights, some new ideas. So who knows? Yeah, I think that's why I advise to read it.
Michael, do you have anything else to add to that?
I started 1 year ago with my PhD in IE around the subject, and I was not, I had no less feeling with it. But with writing this paper, I really get trusted with this subject, so I can advise for everyone who is going to start with IE, this is actually a well-written from base guideline for IE.
Liesbeth, do you?
Yeah, I agree with both of them. So I think AI will have a very important role in radiotherapy in the future. So it's now already coming up, but in the future, it will be everywhere. So medical physicians need to know how to implement it in the clinic and so on. And I think this paper really gives a good overview to do so and give some advice and some techniques you can use to implement it.
Yeah, great. I completely agree. I think that's really where, this paper has come at the right time because people want to know what to do with AI. They know it's coming, and they need some guidance. And thank you for writing this paper and providing that for people. And thank you for joining me. Thank you for joining me on the call today as well.
Thank you.
Thanks for you.
Yeah.
Bye.
I'm going to come back now to that first question that I asked Liesbeth about whether AI makes any difference compared to a standard medical device for contouring. And as Liesbeth said, it does introduce this issue of training and validation. But in an institution where you may want to use a commercial clinical product rather than develop your own, that issue goes away. And essentially we have the same tool for doing auto-contouring as we might have had with previous technologies. So AI doesn't appear to add any additional challenge. As we explored in that conversation with the authors, it could go further when we go potentially towards continual learning of the AI system. How do we continually QA a system that's continually learning? And that's where I think this recommendation has been really helpful in going beyond that initial commissioning to that patient-specific QA and routine QA of AI within clinical practice. Because as we develop a process for doing that routine QA and ongoing monitoring of AI in the clinic, we'll progress what we can do potentially technically with AI in the clinic in parallel with the quality assurance processes that we've implemented. As I said before the interview, there is no substitute for going away and reading the paper, so I'll leave you to do that now, and I hope you'll join me on another auto-contouring review.